diverse meeting designed to cater to all the needs of our various participants. And I should say the participants come from all over the world. Some are clinicians, some are scientists, some are epidemiologists. So some are general practitioners. For example, we had an excellent program on Sunday, Bridging the Gaps, which looked at the importance of blood pressure translation into the field in general practice. And it made the point that the difficulties go far beyond stipulating guidelines which might say blood pressure should be lowered to 130 on 80 or 140 on 90. It talked about the real problems in treating the patient, not just treating to numbers, and particularly where there's low socioeconomic problems that might make the risk factors even more prevalent and make delivery of services more difficult. So that was one example of the sort of thing. And then as a contrast in a way, but typical of the meeting, the next day there was a truly amazing presentation from Eric Olson in the United States about the way in which the molecular junk DNA, so-called, is actually turning out to be really important in cardiovascular risk. And for example, the amazing thing he talked about was that there are segments of the gene in the muscle gene for the heart that are actually communicating somehow, not unknown at the moment, with adipose tissue and can cause metabolic changes. So this is a signal somehow from the heart, a new molecular signal that opens up a whole new vista of physiology, potential therapeutics, and in some way links the heart to what we know as the metabolic syndrome. So that was excellent. We've seen basic presentations of interest to all clinicians on simply measurement of blood pressure, because there's an issue. How do you measure blood pressure? Do you do it with a standard cuff? Do you do it semi-automated? Do you do it at home? Do you do it 24 hours? Do you take into account pulse wave velocity and ankle brachial index, etc., etc.? And the list goes on, and I think doctors find this very confusing to know which is the most appropriate and the most reliable. And so these are issues that were discussed at a number of symposia. Coming up, and no doubt it will, despite the age of the debate, still create controversy, is the salt debate. The question as to whether we should, as a community, have a reduction in our average salt level. And some people might say, well, that should be quite obvious. We should, because low salt is better for you. But there are those who argue, well, in theory that's true, but if you were to apply that to a population, how can you be sure it doesn't come with risks? And those risks might be unexpected. I mean, we might expect some dizziness and some low blood pressure in the summertime, but there may be other things. And so that is still a very active debate, and that'll be played out at the last session of this meeting tomorrow.